Hi, my name is Randy Beckett, and I'm a psychiatric nurse practitioner. And I've been working exclusively in geriatrics for the past 7.5 years, and uh, mostly in, or almost exclusively in nursing homes. And I wanted to talk to you today about the use of antipsychotics in nursing homes. When I first started seeing patients in nursing homes and the new regulations from the Center for Medicare and Medicaid Services came out regarding the use of antipsychotics in nursing homes, there was a lot of uh, fear because for behaviors in nursing homes for decades, there had been the use of antipsychotics, Haldol, Risperdal, then Seroquel to help control behaviors. And when I started seeing patients in nursing homes that had a high percentage of people who were on residents who are on antipsychotics for behaviors, the nursing staff, the administrative staff were, and even the providers, physicians, nurse practitioners that work there were like, oh my God, these patients are going to be climbing the walls. What are we going to do if you take away their antipsychotics? And that didn't happen. People now it took time to taper them off these medicines. It took time and knowledge to find other medications that would help their behaviors. Also, non-pharmacological interventions to help them, because often if somebody is having a behavior, it's because they have an unmet need. So if we can identify those needs and listen to them and try to help with controlling the environment that they're in, where it's not too stimulating and it could be agitating, and things like having staff members not come up behind them and come up and tell them softly what they're going to do before they do it. All these interventions also help control the behaviors. But to review the CMS regulations for the use of antipsychotic in nursing home residents, there are only 3 diagnoses where an antipsychotic can be used according to CMS. And those diagnoses are schizophrenia, Huntington's disease, and Tourette's. Okay. Now, schizophrenia in the elderly, of course, occurs. And in fact, there is a disorder called late onset schizophrenia, where people develop schizophrenia after the age of 50, instead of in their teens or their 20s when schizophrenia usually manifests, but after the age of 50. And it's women, and they tend to have what are called the positive symptoms of schizophrenia. Now, this is not positive as in good. It's positive in that they have delusions, they have auditory hallucinations, they have visual hallucinations. So we're adding something, the disease is adding something into their life. It's an addition, which is the term positive, as opposed to negative symptoms, which are being withdrawn, not wanting to engage, not participating in everything, not talking. Those are the negative symptoms. So with the late onset schizophrenia over the age of 50, then you have these positive symptoms, mostly in women. And this is when these symptoms cannot be explained by another disorder, such as dementia with psychosis. Okay. It has to be differentiated in the diagnosis from, let's say, dementia with psychosis. Okay. So you do have older people over the age of 50 that can develop schizophrenia later in life. And then the use of an antipsychotic would be appropriate for them, not only clinically, but according to CMS. So that would be okay. Now, the other thing that you all know in nursing homes, what we have now are more and more younger people with serious mental illness, such as schizophrenia. There is nowhere else for them to go. They have other health problems that need, intense nursing care, and we don't have home health where they can go, or sometimes they've been homeless, or they were living at home with family members, and those family members may have died or just couldn't take care of them anymore. And so where we used to have institutions in states, mental hospitals, that would take people for long term, we really don't have those anymore. So, and there aren't enough well-staffed group homes to take care of people with serious mental illness, so they end up in a nursing home. So you're going to have people with schizophrenia who end up living in a nursing home, because that's the only solution to their housing and care needs. We have more behaviors, younger people often who are ambulatory, who do not have any impairments in terms of getting around. They're stronger, and who have this serious mental illness, and nursing homes are becoming the new mental hospital institutions that we had prior to the 1980s in this country. The second disease is Tourette's. I can honestly say I haven't had a patient with Tourette's syndrome in a nursing home that I've treated. Now, the third disease is very difficult to manage, and that is Huntington's disease that CMS approves for the use of antipsychotics. Psychosis in Huntington's disease. Also, of course, the chorea, the involuntary movements, and they can be aggressive and agitated and seriously cognitively impaired. And so the antipsychotics are not only indicated, but approved by CMS for that use. And it's really difficult a lot of times to help with the psychosis and the behaviors that people with Huntington's disease have, even with antipsychotics. So schizophrenia, Huntington's disease, Tourette's. And the reason these have been restricted is because we know that these antipsychotics in older people lead to serious heart disease, and they die earlier. So this is not something we want to use. These drugs, antipsychotics, are not something we want to use in the general population for dementia with behaviors. Okay, there are lots of other things, non-pharmacological interventions. And of course, this can be a struggle right now with the staffing issues that we have in nursing homes due to COVID. And it's always been a problem, really. It's just worse now. But the non-pharmacological interventions, as well as other medications that we can use, antidepressants, mood stabilizers, those kinds of medications, sometimes benzodiazepines, that can be useful for helping people with behaviors, and also pain. People often have pain that's undiagnosed and not treated properly, that's causing the agitation. And of course, now with us shutting down and keeping people in their rooms and having meals in their rooms, that adds a whole nother level of complication. So my experience in dozens and dozens of nursing homes with hundreds and hundreds of patients, many of whom were on antipsychotics, and the nursing homes had 30, 40% of their patients on antipsychotics for dementia with behaviors, and we were able to get them down below 10% or even lower with these interventions that we've discussed today. Now, there is, and there are the rare resident, they are fairly rare, who will have a dementia with psychosis, or perhaps bipolar disorder with psychosis that has not been responsive to other medications like lithium, lamotrigine, Depakote, and dementia with psychosis, where to the point that they can have such serious hallucinations and delusions that they're violent and a risk to themselves and others. There are times when an antipsychotic is necessary to protect the safety of the resident who is ill and other residents, because there may be resident-on-resident aggression, and of course the staff. And these should be used very short term and well documented in your nursing notes and behavior charting, and also by the provider to show why it was necessary. But these are by far not the rule for the use of antipsychotics. These are the exceptions and are not common, I should say. So just a reminder about the use of antipsychotics in nursing homes, that it can be accomplished to reduce the use of them. It's important to get administration on board with this idea. It's important to get nursing staff educated and on board with this idea. It's very important to get other providers, such as primary care providers, physicians, nurse practitioners, physicians assistants, on board with this idea that yes, this can be done by a psychiatric provider. This can be done. It is a coordinated effort between the administration, the nursing staff, the medical staff, such as the PCPs, and everybody in the facility, as well as your psychiatric nurse practitioner. But it can be done, and it's important to do it first for the resident so that we're not causing early death in these residents or falls due to sedation associated with the use of these antipsychotics. And for the families, so that they know, and loved ones, that they know that we're doing the best we can with the proper medications. And finally, of course, for the nursing homes, because this affects your management of the facility and its relationship with CMS and surveyors if these antipsychotics are not reduced and not addressed properly, so that you can remove them from the use in these residents. So thank you very much for listening today. This is an ongoing issue. Actually, what we've seen, there's been a slight uptick in the use of antipsychotics in nursing homes across the country during COVID. In 2021, there's more behaviors, there's more stress on the residents, there's the staffing issues, but it's very small, and we really need to concentrate on this for the benefit of our residents and for everyone else involved in the nursing home industry. Thank you very much for your time.